Hey, podcast listeners, Fawaz Al-Mufti here from Westchester, New York, and this is the Neurocritical Care Society podcast. Seizures are a feared complication of intracerebral hemorrhage, both acutely and years after the initial hemorrhage. Furthermore, they may potentially lead to increased intracranial pressure, cerebral ischemia, and even worse inpatient outcomes. So prophylactic seizure medications is a reasonable therapeutic strategy if the treatment carries a low risk of complications and the patient has an elevated risk of seizures. But have you ever wondered at what price? What are the short and long-term effects of these anti-seizure medications on cognitive function, for example? Should there be some sort of balance? Or is it a one-size-fits-all? When should we reconsider subjecting our patients to prophylactic seizure medications? Today, Mike Brogan is joined by Andrew Naidech, who will be discussing on behalf of his co-authors the recent critical care medicine publication entitled Prophylactic Seizure Medications and Health-Related Quality of Life After Intracerebral Hemorrhage. I hope you enjoy this episode.
Hi, this is Mike Brogan. I'm a neurointensivist at Regents Hospital in St. Paul. Today I'm interviewing Dr. Andrew Naidech from Northwestern University. We're going to discuss his recent paper in critical care medicine titled Prophylactic Seizure Medication and Health-Related Quality of Life After Intracerebral Hemorrhage. Dr. Naidech, welcome to the podcast.
It's great to be here. Thank you for having me on the show.
First, can you give our listeners a little background? How significant a problem are seizures after ICH? How do clinicians assess that seizure risk? And how have we typically approached this problem?
This has been a moving target for almost 20 years. About 20 years ago, guidelines for both subarachnoid hemorrhage and intracerebral hemorrhage stated that prophylactic seizure medications should be given to reduce the risk of seizures. And probably this goes back to the original Temkin study in the New England Journal of Medicine, looking at prophylactic phenytoin to prevent seizures in patients with severe traumatic brain injury. However, while we were working on this problem as a fellow, using a database at Columbia, the Subarachnoid Hemorrhage Outcomes Project, started by Stefan Mayer, in fact, we found that the more seizure medications patients received, particularly phenytoin, the more complications, such as fever, the patients had, and the worse the outcomes were, with both functional and cognitive outcomes. This has led to changes in practice and the subsequent abandonment of phenytoin in short order, starting after in 2009 and 2010, after we published data in intracerebral hemorrhage and the guidelines changed. I foolishly thought at the time that people would simply stop using phenytoin, but what in fact happened is that the world seems to switch to levetiracetam for prophylactic instead, and the overall number of patients with intracerebral hemorrhage who received prophylactic seizure medication actually slightly increased over that time period. And so this study was a follow-up question: does levetiracetam seem to change outcomes as well? Because by the time we began collecting data for this subsequent analysis, we had subsequently, and most systems had subsequently abandoned the use of phenytoin.
Tell us about the study design in this case. What were the protocols for assessing seizure, and how were the health-related quality of life outcomes assessed?
Our protocol for assessing seizure in the intensive care unit is similar to most protocols, similar to the guidelines. In general, if a patient has blood in the intracranial space and altered consciousness, that patient undergoes EEG monitoring for at least 24 hours that is reviewed by a certified epileptologist. We've noted in the past that our rate of non-convulsive seizures detected in EEG monitoring seems to be lower than other centers. This is probably due to some combination of readers who might consider EEG readings to be abnormal, but perhaps not strike that. Our ICU protocol is similar to most ICU protocols in that patients with intracranial hemorrhage of any sort and altered consciousness undergo 24 hours of EEG monitoring reviewed by a board-certified epileptologist in our epilepsy monitoring unit. The protocol for assessing health-related quality of life is that patients, once prospectively identified, were contacted at follow-up for quality of life assessment reported by the patient or a proxy, such as a spouse, with the NIH Patient-Reported Outcomes Measurement Information System, and NeuroQual, which is a related set of instruments specifically for neurologic patients, especially physical function, cognitive function, fatigue, and so on. We've been doing this since 2011 or so on a research basis, and more recently for routine care, but some centers have been getting patient-reported outcomes at every patient touch for years and have tens of thousands of data points to work with. For this investigation, we used the several hundred patients and data points that were available as part of an ongoing research study.
So let's talk a little bit about the acute phase first. Who in your study seemed to receive prophylaxis, and how common were issues with delirium and seizure?
It's previously well described that the patients at highest risk for seizures after intracerebral hemorrhage are patients with lobar hematoma location. And this makes sense. It's nearer the cortex where most seizures originate, and so you'd expect an irritant like blood to lead to more seizures in those patients. And it is, in fact, exactly what happens. We've previously published that in large data sets, there's an apparent racial ethnic disparity, with white patients approximately twice as likely to receive prophylactic seizure medications as black patients. And it turns out that this is really confounded by hematoma location, where black patients had more hypertension by history, higher blood pressure, and more basal ganglia hematomas that were less likely to have seizures. White patients in our cohort tended more likely to have amyloid angiopathy, had more lobar hematomas, and were simply more likely to have seizures. So the group of patients that we're really talking about as a subgroup are patients with lobar hematoma location who are most likely to have seizures, and in fact, you'd expect would be the patients most likely to benefit from prophylactic seizure medications.
And in the acute phase, how often did you find seizures, and what kind of challenges did you have with delirium?
Our rate of seizures in the patients that we've studied is fairly low. It's between 5 and 10%. And we've been fairly strict about the definition: clear electrographic seizures or clear clinical seizure activity as described by a bystander. This does not take into account all of the various abnormal EEG patterns that are abnormal but not epileptiform per se. So PLEDS, PLEDS plus, generalized periodic epileptiform discharges, and this whole ictal-intra-ictal continuum has not been well characterized. It's worth noting that if all of these patterns had a higher risk of seizures and worse outcome, you would expect the bias to be towards seeing a benefit of seizure medication rather than the results we found. In terms of delirium, we specifically looked for delirium in this cohort because delirium is already well described as a prominent predictor of worse cognitive at follow-up. And so we felt it important to control for delirium. We and others have previously published that delirium in neurologically critically ill patients leads to worse outcomes at follow-up, particularly in cognitive function. In the paper, we present the work on delirium, the nursing assessment, all the data, as a way to show that this was not a confounder. It turned out that delirium didn't impact the relationship we described with levetiracetam and worse outcome, and we found that levetiracetam was not associated with delirium. So in many ways, it's a bit of a nothing burger. It's just there to show that we thought about it and were careful to exclude a relationship of levetiracetam and delirium as a confounder of worse cognitive function and follow-up.
Thank you. Now let's talk about that cognitive function follow-up. What did you find in terms of the outcomes, and how clinically meaningful are score shifts of this magnitude?
We found that specifically in the domain of cognitive function, the patients who received prophylactic levetiracetam had on average about a half a standard deviation of worse scores in cognitive function. This is a substantial difference. Pre-existing stroke literature that a half a standard deviation is typically considered clinically meaningful, and that's about the magnitude of the difference we found. A half a standard deviation is the difference between, for example, having a little trouble and moderate or a lot of trouble balancing one's checkbook, remembering to take medications, understanding new directions, and being able to live independently. How you can map scores of quality of life from NeuroQual and PROMIS onto what patients say they can do is available on the Health Measures website, healthmeasures.net. And you can see all of the questions and how they are mapped to specific scores of quality of life.
As I read your paper, it appeared that clinicians were correct in their assessment of patients' risk for seizures, but I was surprised that this effect on cognitive outcomes was seen from a fairly low dose and relatively short administration of the medication, and not to the delirium, which I would have expected to be more common. What's your take?
The idea that levetiracetam might worsen cognitive function wasn't surprising to us. In fact, it's clearly stated in the package insert. We didn't make it up. You're right. Would you expect relatively short doses and a relatively short duration to lead to cognitive dysfunction? However, an injured brain is very susceptible, and we found, as we present in the paper, that there was a dose-response relationship with the more days of levetiracetam and the more milligrams received, and almost all patients received 500 milligrams every 12 hours, the usual dose, the more they received, the worse the cognitive outcome and follow-up. As you might expect, the effect was most prominent at 28 days and seems to wear off a bit over time and wasn't still visible at a year out. But this is what one would see with almost any neurotoxin. In studies of haloperidol, you'll find worse cognitive function acutely that gets better over time, and phenytoin as well. In our original 2005 paper on prophylactic phenytoin and outcomes after subarachnoid hemorrhage, the more phenytoin patients received, the worse their cognitive function scores acutely, and the more they improved over time, almost but not quite catching up later on. So levetiracetam might have similar effects to phenytoin on cognitive function, except the effect, as you would expect, is milder. This would also explain why phenytoin, for example, doesn't impact motor function and doesn't seem to be associated with an increased risk of fever. Let me be clear. This paper is broadly in line with exactly what you'd expect. Levetiracetam does seem to be better tolerated and have fewer side effects compared to phenytoin. But it's not harmless. It has well-established side effects which are clearly labeled in the package insert, and they're clearly detectable when they're used in substantially sized cohorts, and you can find differences that follow up with readily available tools. That being said, the effect we found is really mostly limited to cognitive function. It does not seem to extend to functional outcomes like the Rankin scale or functional outcomes like mobility on quality of life. A way to extend this work would be to do objective cognitive function tests like the NIH toolbox, and that just wasn't the investigation we did.
Based on your answers so far, I'm pretty sure I can guess your thoughts on this, but thinking about the practice patterns in the past and the shift from phenytoin to levetiracetam for ICH-related seizures, what would your paper suggest in terms of seizure prophylaxis going forward, and how does that relate with the current guidelines?
So we would suggest that patients not receive levetiracetam for seizure prophylaxis going forward, although some clinicians may still choose to do so in specifically high-risk patients. When we found that phenytoin was associated with worse outcomes, I foolishly thought that physicians would simply stop prescribing phenytoin, but they simply switched to levetiracetam. I hope that clinicians don't switch from levetiracetam to some other seizure medication, because in fact, levetiracetam is probably still the safest one available and has the fewest other side effects, particularly in terms of cardiovascular side effects.
Any important limitations to this study that you would like to comment on? For example, any relationship to long-term seizure risk that you're aware of?
There are many limitations to the study. This is mostly a single-center cohort over a few years. Large data sets would be very helpful, and relatively few centers have the long-term quality of life data available in follow-up or the in-person cognitive test needed to do this sort of work. We use fairly standard multivariate regression models, but some would say that's actually not the way it ought to be done now, and in fact we should have set up what would in essence look like a randomized experiment with equally matched patients, perhaps only of lobar hematuria, who received and didn't receive levetiracetam, and then were assessed at outcome. That would be another way to do this investigation. That's simply not the investigation we did and the analysis we did at the time.
Dr. Naidech, we appreciate you taking the time to speak with us. This is an important topic. Thank you very much.
It was fun to do. Thank you so much for having me on the program.
The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Romani Ballou, Mike Brogan, Josh Levine, Sarah Stern-Nezer, Benjamin Miller, Storeen Shepard, and Chris Zammit. Our senior producer is Jim Siegler. Our administrative staff include Angel Gindel, Sarah Memon, and Becca Stigman. Music by Lee Rosever under a Creative Commons license. The Neurocritical Care podcast series is available on NCS On Demand and wherever you may listen to your podcasts. For more information, please follow us on Twitter at Neurocritical or Facebook. I'm Fawaz Al-Mufti, and thanks for listening.